Good evening, everybody. I'm Lloyd. Thank you very much, Angie, for the introduction and for letting me talk this evening. I've just been asked to give a little brief update on some data on childhood influenza that we've collected in 2023. I know we just did this, but I'm very new to this place, so it's beautiful land here, and I would also like to acknowledge the Gindji people as the traditional custodians of this land. And also to thank you to Dr. Mohan, who's been helping me a lot with this presentation and for giving me the opportunity. So just wanted to provide a little bit of background on influenza in childhood. So from a paediatric perspective, influenza most of the time tends to be quite a benign and self-limiting illness. We do know that children who have chronic illnesses are more likely to get severe cases of influenza, but on the same token, almost half of the severe influenza we see is in children that are actually previously well. So there is a bit of a balance between both there. We also do often get quite a lot of questions about whether antiviral treatment is recommended and where indicated that needs to be started within 48 hours of the since the onset of the disease. And obviously the reason we're all here tonight, but we know that influenza vaccination is the most effective form of prevention and is strongly recommended for all children over 6 months of age. And then we know in our younger cohort of children that younger children are more likely to have severe disease. They're also more likely to present with non-respiratory manifestations, so less likely to have respiratory symptoms and more likely to have either gastrointestinal or neurological features as well. So just looking briefly about the data. So thanks to CaseMix for providing this to us. So this was from inclusive of all of 2023. It was data based on positive influenza PCR results through ED and then also admitted to the paediatric ward. So this would include people admitted, children under paediatrics, and then also under surgical subspecialties like appendicitis who happen to have flu. And obviously this is only data that is including positive swabs that were taken in this hospital. So it's only a very small snapshot of influenza in the community. So to keep that in mind. So this was the monthly data on influenza positive results throughout the year. So I guess this data kind of shows that influenza is kind of present all year round. So even through the summer months, there's still a reasonable amount of children that were testing positive coming through the ED, obviously with a spike there in the winter months as well. And then if we overlay that with the blue, which is the inpatient admissions, we can see that the vast majority of our inpatient admissions with influenza does occur in the winter months, indicating that this is likely the more severe end of the disease, I guess. So I just thought that was quite an interesting comparison there, but the data broadly follows one another, but definitely with admissions, it's winter time that we see the most. And unfortunately, like all too many of our health issues, our Aboriginal and Torres Strait Islander community is adversely and disproportionately affected. So we can see that more than half of those who tested positive to influenza were of Aboriginal and or Torres Strait Islander descent as well. Just looking briefly into the length of stay, I've tried to sort of arbitrarily break up as in sort of 2 years and under, and then the sort of preschool, like primary school, and then high school age children, and the number of admissions there within. We can see that obviously that the younger children tend to stay in hospital just slightly longer with an overall average of just 1.7 days. And then looking at the underlying reason why these children presented to the hospital, again, the vast majority being other respiratory tract infections, fever, and poor intake, or a combination of all three, again, making up the vast majority. We saw that about 10% of those with respiratory tract signs did end up having a secondary bacterial pneumonia, so not an insignificant proportion, although obviously that is, I guess, biased sample because it is those that actually came into the hospital. We saw a few with febrile convulsions. Again, myositis, not an uncommon presentation of influenza, particularly sort of bilateral lower limb myositis. Even in the last couple of weeks I've been here, I've seen a few kids who come in being unable to walk without any respiratory tract signs. And then a few at the bottom like I said, children who came in with appendicitis and other sort of issues that were clearly not related to their influenza. And then we do sometimes get asked advice on whether influenza needs to be treated. We have a couple of agents, so oseltamivir being the oral therapy, and then peramivir, the IV therapy, neuraminase inhibitors can reduce replication and seem to have a modest effect on reducing the symptoms and decreasing, I guess the role is really trying to prevent the more severe disease and need to be started within 48 hours in order to be of most effectiveness. We don't use whether a child is vaccinated or not wouldn't influence whether or not we decided to commence treatment. The indications for treatment would be basically if there's risk factors present, so if there's severe chronic disease, genetic conditions, prematurity, and immunodeficiency. And then if obviously if children are presenting with severe disease, no matter what their background is, whether that's requiring respiratory support, obviously encephalitis, myocarditis, pericarditis, or quite severe manifestations of disease. So in terms of dosing, we have a prophylaxis and a treatment dose, with daily being prophylactic and twice daily being the treatment dose. So treatment is basically if a child has tested positive, prophylaxis would be for a child with risk factors who had been exposed. The common side effects being nausea and headache that we kind of know about for these medications. And really to kind of emphasise how few children we actually give this to. Of all of those 121 admissions, we only gave oseltamivir to 4 children. And I believe we ceased it in 1 child who came in on it. And one of those children was in ICU. So, yeah. So in summary, we had 121 children last year who admitted to Cairns Hospital with influenza. The vast majority were not treated with any antivirals, and the mean length of stay was less than 48 hours in hospital. And again, reiterating the point that our Aboriginal and Torres Strait Islander children are disproportionately affected by influenza. So thank you for your time, and happy to take any questions.
It's good to have a good insight as to why we're vaccinating. The next, Carly Thirlwell from our team, communicable disease control. Thanks, Carly.
Hi everyone, just me today. Juliet's down at Byron Bay, lucky thing. So communicable disease control, what's going on? I'm going to be like 5 minutes, I'm going to whip through so we can get to the main event. Basically, we're seeing our typical influenza peak. So we know in the tropics we generally see 2 peaks for influenza. So usually around this time, and then later on in winter when we get our bigger peak. Unfortunately, we've never got our flu vax before we start having this early peak. Also pertussis. Pertussis is across the state, numbers are increasing. So our public health alert was sent out from the communicable diseases branch back on March. We can see sort of post-COVID, obviously, with all our respiratory precautions we were taking and our not travelling and our socially distancing, pertussis notifications have been very, very low, but we're definitely seeing an increase from, you know, the end of last year up through now. So who's most at risk? We know babies who are too young to be vaccinated, and unvaccinated infants and children. And we know that vaccination is the best form to prevent these vulnerable populations getting unwell. So you guys know the schedule well. I won't go through it, but certainly that's what our schedule's geared up to, is to protect those most vulnerable. Then, of course, vaccination for women in every pregnancy that they have. And it's also recommended for healthcare workers, early child care educators, and any adult caring for infants. And we did clarify today, I think, from infection control that you, Queensland Health staff, are able to access a booster every 10 years. That's right, Ange, wasn't it? Yeah. This is really busy, but I just wanted to give you an understanding of where we come from meningococcal vaccination. So you can see this is data that's been right back from 2020, looking at the serotypes that we've had through the years. So you can see certainly with the blue C vaccine, so once that became widely used, how our numbers decreased. when ACWY was introduced, and then obviously this residual peak, we've just been seeing men bees basically. I think our last case, we had one last month. And a couple of years ago, you might remember we had a high school that had 3 cases and we did a big response at. So men B is basically all we've been seeing here. So, and obviously now we've got the vaccination introduction. Moving on from our non-vaccine diseases. So we're looking, it's our usual wet season melioidosis. And of course, we've had a lot of cases because of the flooding. So that's a bacteria that lives in the soil. Once we get a lot of water, it raises up to the surface. So our most vulnerable patients are those with chronic illness. So we're seeing nearly everyone we have has got diabetes or a chronic lung. So it's really important, especially if you're out in general practice, if you've got your chronic disease patients, that you're educating them, that you educate them about this, because these patients are a great burden on the health system. They end up in hospital for a long time and often quite unwell. Crypto, so we're seeing lots of crypto at the moment. That's not just in Cairns, but also across the state. So you can see we've got a massive peak at the moment. Year to date, we've had 67 cases. We've usually had around 20. And of course, this would be the tip of the iceberg because not many people are presenting if they've got diarrhea symptoms to GPs or putting in for a test. So we assume, and often if we hear of one crypto that's been confirmed on a stool specie, then we ring them and the whole family's had it. So we would assume that that number would be much higher. AVL, so the most important message is always to remember that there's no level of immunity that's recognised as being protective against rabies. So anyone that's coming in with a bat bite or a scratch needs prophylaxis regardless of what vaccine they've had prior. So obviously if they've had a course prior, 2 booster vaccines, if they haven't had any vaccines in the past, then they need immunoglobulin and 4 rabies vaccines. We recognise what a pain it is for ED staff at Cairns Hospital when everyone has to come to them for their immunoglobulin. We've been trying to advocate for that to be sent out to other EDs, especially up on the tablelands, but because it's such an expensive drug, they are not happy to decentralise that as yet. Another alert that's just come out from public health is a likely shortage. I'm not sure if everyone recognises that yet, but certainly there is a likelier shortage and they're recommending ivermectin in the interim. And last but not least, I just wanted to flag that the ARFRHD notifications are coming back to local public health units across the state. So at the moment, as you guys would know, the register receives all the notifications as well as doing grassroots education and clinician support by SIL and recall. They do the whole thing. That program has been dismantled and the register's moving back to QFAS, so back into the Department of Health, and they'll still be responsible for doing recalls and things like that. But the actual notifications and working through those notifications will be coming back to the public health units with a strong emphasis on it's expected that the clinicians will be driving any kind of follow-up that might be needed. And that's it. Any questions? No. Short and sweet.
Thanks, Carly. That's great. All right, so this is sort of the main reason why everyone's here, and then I'm going to be actually talking about the vaccine programme and how it's going to be run and eligibility. We've had a great presentation from Dr. Lloyd-Snook about the rates of influenza last year. So I just briefly point out that the graph on the far left over there is our lab confirmed cases last year in 22 and 23, and you can see that it was definitely around the June, July, August time that we had our peak, and the red line is the children under 16 years old. And then the graph here just on the right, that is presentations to ED. And again, you can see that this is the 0 to 16-year-olds. There was a lot of 0 to 16-year-olds in ED at that time. And the purple line is just showing how many of them went on to be admitted. So we know that vaccination is one of the most successful and cost-effective advances in global public health. So the best way to avoid flu in our community is to try and get as many people vaccinated as possible. And the way how Queensland want to do that this year is there's going to be 2 programs. So the first one is the National Immunisation Programme, which is what you're all familiar with. It happens every year. This time of year, you all become incredibly busy in primary health because patients that come in, those sort of certain age groups line up at the door for their flu vaccines, and then there's lots of other vaccines you can potentially offer at the same time, and health checks and things you can do. So we're aware that you guys are really busy at this time, and there's not a great deal has changed with the National Immunisation Programme. I'll go through that in just a moment. But this year, Queensland, so it's not Commonwealth, Queensland is doing the free flu programme. So they ran it last year for just a couple of weeks during that peak that I just showed you. They started to do a free flu programme. And it's only going to be funded until September. And all Queensland residents over 6 months of age who are not NIP eligible, so actually it would be from 5 years because under 5 you are NIP eligible. So it's kind of like your 5 to 64 year age group. So the group of people that would normally go to their GP or their pharmacy and pay for the vaccine. So you can go to, anyone is eligible for a free flu vaccine now. And the way how this second programme works, there's a whole website about it. And GP practices, primary health pharmacies, they purchase the stock privately. So you cannot use NIP stock for this free flu programme. The National Immunisation Programme is very different to this free flu programme. So you have to obtain the vaccines privately first. And then every couple of weeks, you fill out the forms for reimbursement, and the government will reimburse you for those flu vaccines given. And it's just for the vaccines actually administered. So if at the end of September, when this programme runs out and you've got a huge stock of flu vaccines, you're not going to be able to apply for reimbursement. You can only do it in that amount of time that's available. And you cannot use NIP stock. You can't use your NIP stock and then apply for reimbursement. So 2 very separate programmes. So just try and be mindful that they're separate. And everything is on this 2024 free flu vaccination programme website. So please read that if there's any confusion, and that's where it's got the reimbursement forms as well. Now, in January this year, pharmacists became eligible to administer National Immunisation Programme vaccines. So they can also do the reimbursement programme. So you can go in and get a free flu if you're not eligible for NIP vaccines. But if you are eligible for NIP vaccines, you can go into your pharmacy and get that flu vaccine. But they're also going to be giving adolescent and older adult vaccines from the National Immunisation Programme. And there's this website here, and it's been abbreviated down to NIPVIP. That's kind of what we're how it's described. And any pharmacy that has now given national immunisation programmes has gone through the same procedures and protocols and authorisation as we would for a general practice. So originally, when they were giving the national immunisation programme flu last year, if they were already giving COVID vaccines, they allowed them just to have NIP stock. But now they've had to go through quite a big process, and we've had Karen employed as the pharmacy public health nurse, and they've all had site visits, and they should all be, their vaccine management should fit the criteria of everybody else. That's just what their order form looks like. So just to give you an idea, it is only sort of adolescents, and there's no childhood vaccines on there at the moment. There's just, probably that will come. They'll probably start to give young children their vaccines. You'll be able to go to a pharmacy and get your childhood NIP vaccine, but it's not happening at the moment. It's just going to be those adolescent vaccines while they sort of ease themselves into the programme. And obviously they've got quite a lot of workload, additional workload with this as well. So I'm going to talk about the National Immunisation Programme, which you're all familiar with, and there's not a great deal of change, fortunately. So if you've been in general practice or primary health, community health for a long time, it's all very similar. The 2 most noticeable difference is that we have the flu cell quad this year on the programme, and there's some changes to the medical at risk category, or the way how they've described it has just changed a little bit. So it looks like it makes it look like more people that's eligible to have the vaccine. Cell-based vaccine was used last year, but it wasn't on the National Immunisation Programme. And the cell-based, it refers to how the influenza vaccine's made. So most of the inactivated flu vaccines are grown in eggs, as you probably know. But the cell-based vaccines are grown in cultured cells of mammalian origin instead of hen's eggs. And the cell-based vaccines, they offer better protection, so they can probably mimic more of the circulating wild flu viruses than what is grown in eggs. And they're able to produce large amounts as well. So with the cell-based vaccines, they're not dependent on the supply of eggs. So in the future, with future outbreaks or pandemics such as COVID, it's advantageous in that situation. And this flu cell vaccine is only going to be available on the NIP for 5 to 64 years, but it is actually licensed from 6 months of age. It's just that's a funding, they've just chosen to keep that in that funded category there. And then your medical at risk, it's very similar to all the previous years. So you've got your standard cardiac disease, chronic respiratory, immunocompromising conditions and hematological disorders, chronic metabolic disorder, so your diabetes and all of those conditions, kidney disease and neurological disease. And then it always has the long-term aspirin therapy in children aged 5 to 10 years. And then it's just sort of highlighted this bottom section. I think it might have possibly been incorporated to the previous one, but they've sort of spelt them out a little bit more this time. So we've got chronic liver disease, obesity, chromosomal abnormalities, and harmful use of alcohol. What it mentions also with asthma, sometimes lots of people telephone us about whether they're eligible to have the vaccine with asthma or not, but it just says frequent medical consultations or multiple medicines. So you can use your own interpretation as whether you think they'll be eligible for the flu vaccine. But what is new just down here, which we really like, they've actually said these examples are not exhaustive and providers may include individuals with conditions similar to these listed based on clinical judgment. It's kind of giving you a bit more of a license to, your phone calls when you ring us. Do you think this, with this condition, is eligible? Then I think it's just allowing you, if you really think that somebody needs a flu vaccine funded, then you can have that. Your ATAGI statement, you should be familiar with. This is the ATAGI statement spells out a little bit more details what's in the vaccine, and it's the same as previous years. It's a quadrivalent vaccine, and it contains 2 A strains and 2 B strains, and it's just the A strains are a little bit different this year to last year. And then the bottom section here, they always show this section, and this shows you all the vaccines that are available in Australia. And the ones with the little green arrows that I've shown, they're the ones that are going to be on the National Immunisation Programme. So for your children under 5 years, you've got your Vaxagrip Tetra and Flurix Tetra, and then funded is the Flucelvax from 5 years to 64 years. And then a Fluriquad, it's the same as last year. You can't have it under 5 years of age. And then Fluquadri and Influvac Tetri, they'll be available privately. And Fluad Quad, same as previous years. We want the Fluad Quad to be used for over 65s. If anyone wants sort of a high dose flu vaccine younger than 65, from 60 years of age, the Fluzone is available on the private market. And Fluad Quad is only available on the National Immunisation Programme. Hopefully everyone's either grabbed one today or has some printed on their desks. This is on the National Immunisation Programme website, and just have it handy for when you're choosing which vaccine to give your clients. It spells out more or less what I've just said, so from 6 months of age to less than 5 years. So we don't give flu vaccine under 6 months of age. And then for your 5 to 64 years, you've got 3 brands there. And then it's sort of highlighted in red, Fluad Quad, please only use that for 65 and over. It's not licensed under 65 years of age. Just try and have these documents handy on your desktop or printed. Your ATAGI statement is a must, really. And then this National Immunisation Programme one here, it's got a bit more information than the ATAGI statement, and it's got some bit more description about the vaccines. So just so you can have those discussions with your patients and you want more information. And then the NCRS has just launched their frequently asked questions as well, which they do every year, and they've just added the 2024 FAQs. And then I didn't put a picture there, but your Australian immunisation handbook is always your go-to, and will always, now it's online, it has the most up-to-date information in the handbook. So please make sure that you've got all of this information handy when you're offering the programme. And then just, so the only real contraindication to giving influenza vaccine is anaphylaxis following a previous dose of any influenza vaccine, or anaphylaxis following any vaccine components excluding eggs. Latex, there's no worries with latex allergy. All the national immunisation programme are latex free. And then egg allergy, previous years it says there's no contraindication to egg-based influenza vaccines, but if there's any significant concern, just make sure that the vaccine's administered in a primary care setting and not in an outreach situation, and always get your patients to stay up to 30 minutes, or definitely 30 minutes when there's any kind of risk of anaphylaxis or not anaphylaxis, or any kind of allergy to anything that's in the vaccine, or egg allergy. Please notify us with adverse events. It's so important for the TGA and the pharmaceutical company. I know they're a little bit time consuming when you're really busy, but it's really important that pharmaceutical companies get to know what kind of side effects are happening with their vaccines that they're putting out there in the market. Anything that you need to know about the Queensland Immunisation Programme, which is the National Immunisation Programme, is on that Queensland, that QIP website. So you go onto the QIP website and then you just click Queensland Immunisation Influenza Programme. And that's all the information that you'll find on there. So, and all these sort of ATAGI statements and information that I'm talking about tonight, everything's on that website. You can, or you can go via the immunisation handbook as well. So please be familiar with this website, because you're providing the influenza programme, and it's important that you know all the background information from the programme that you're running from your clinics. So eligibility criteria, again, this hasn't changed. So just, we don't give the flu vaccine to children under 6 months of age, but it's free for all children from 6 months of age up to 5 years of age. And if it's their first year of receiving the vaccine, they actually get 2 doses 1 month apart. But if they only receive 1 dose and they come back the following year, you only give 1 dose subsequent years. You don't go back to giving 2 doses because you missed the first one. So it's only that very first year that you give the 2 doses. And then it's funded for all adults over 65 years of age, and that's the adjuvanted Fluad Quad that we recommend for this age group. And because of the adjuvant, it gives a better immune response for this particular age group that need more of a boost, and it lasts for longer as well, the immune response. So please make sure that they're getting the right vaccine for their age group. So all Aboriginal and Torres Strait Islander people from 6 months of age and over are eligible for the flu vaccine. Just make sure that when you've got somebody and you're giving them the age appropriate vaccine. And then I have got a slide on pregnancy in just a moment, so I'll just talk about that. And then people aged 6 months and over who have a medical condition that's associated with an increased risk of influenza disease and its complications. And I've just shown you that table a few slides back. So if you've got someone who fits into that category, then they are funded for the influenza vaccine. And just if you have got somebody who's really severely immunocompromised, it's important that you make sure that their friends or people live in the same household are vaccinated as well, to offer that herd immunity and protection of the person. For pregnant women, so it's recommended and funded at any stage of pregnancy, the flu vaccine, and it protects both the mother and baby for the first few months, mother and then the baby for the first few months of life. And so for women who received a 2023 influenza vaccine during pregnancy, it is recommended to also receive a 2024 vaccine before the end of that pregnancy. And then if you've got a woman who received an influenza vaccine, say a 2024 influenza vaccine, before becoming pregnant, she should actually be vaccinated again during that pregnancy to protect the unborn infant for those first few months of life before they're old enough to be vaccinated. And it is safe to administer the influenza vaccine at the same time as pertussis, which is given between 20 and 32 weeks, although pertussis can be given up to any time before birth, so long as they're not before 20 weeks. And influenza vaccine can be given at the same time as a COVID vaccine or any of the vaccines that are indicated during pregnancy. So in general, influenza vaccines can be administered at the same time as or at any interval before or after vaccines. So if a person presents for another vaccine, this is a good prompt to consider influenza vaccine at that time. And don't forget, with your older adults, there's lots of you could be considering the shingles vaccine and the pneumococcal vaccine, and there's even the private RSV vaccine, Arexvy, that's coming out now. It's not funded, but it's private. So if you've got somebody coming for a flu vaccine, hop onto air, look at their age group and consider what other vaccines you can be offering to give good protection for vaccine preventable diseases that are out there. There is limited data on the co-administration of adjuvanted vaccines. So Fluad Quad and the Shingrix vaccine, while it's preferred to separate administration by a few days, it is acceptable to co-administer these vaccines to avoid missing opportunities. So I will just chat a little bit more when I talk about shingles in just a moment. And all this information about co-administration, it's on the ATAGI statement that I showed you, and it's on the NIP fact sheet that I showed you as well. So these are the sort of questions that come up when you've got your clients in for vaccination. And this is just some data taken from Ausvac Safety, and this is for children 6 months to 5 years. And this is the commonly reported adverse events. And with children, the most common is local injection site reaction, fatigue, and fever. We don't routinely recommend Panadol prophylactically for vaccinations, apart from Bexzero. Which obviously, if a child has a high fever, you would be giving Panadol. And then you don't hear so much about headache and joint pain, but if you've got young children, they probably can't always verbalize what they're feeling anyway. But with our 60-year-olds and over that have received either the adjuvanted or the high dose, their sort of biggest reaction is the local reaction, and they sort of describe more sort of fatigue and joint pain and not so much fever. So you'll always get those patients that say, the flu vaccine gave me flu, but we don't see a great deal of reactions, probably more just with the adjuvanted Fluad Quad. People do get quite sore arms from that one. So hopefully you should all have Fluad Quads in your fridges right now and be vaccinating that. So once a flu vaccine arrives in your fridge from the National Immunisation Programme, you can start giving that vaccine straight away. Everyone should have received this letter from QIP as well. And we did just have to confirm with QIP a couple of days ago to make sure that you do have to actually order your Fluarix Tetra, Vaxigrip Tetra and Flucelvax next week on Tuesday, the 2nd of April. I think we're all quite used to that first round of vaccines just arriving, like the Fluad Quad just arrived. I don't think they've probably sent the messaging quite as well as they should, because a lot of people aren't aware of that. But please make sure that you put your orders in next Tuesday, so you start to get those other vaccines, so you can start vaccinating your younger adults. Anyone under 65, because you've only got the under 65 vaccine at the moment. So that's the flu programme. I'm going to go on now and just talk about the update on the schedules. Maybe ask questions at the very end if that's okay, just because this has been recorded and it just helps keep the presentation smoother. So if you've got any questions, scribble them down and we'll have a chat at the end. So we've got new immunisation schedules, and I don't think anyone's that enthralled with the new schedules that have arrived. Quite a few people have commented and said that they're quite difficult to see. What they've done, they've made it in keeping with the National Immunisation Programme schedule. So they're almost identical to the NIP schedules. So quite different to what we're used to looking at with the Queensland ones. What's new on this is the childhood schedule that's on the screen at the moment. So obviously Bexzero was already there for our Aboriginal and Torres Strait Islander children, but it's now there for all children, which I'll talk about that just in a moment. Shingrix was added in 2023 to the adult schedule, and just this little section's just talking about changes. And unfortunately, QIP, they're no longer printing the schedules, which I know everyone is very disappointed about that. And I know some of you don't even have colour printers. And the idea is that you're supposed to keep looking at it online, because online's the most up to date, and if they make any changes, they can just change it. But yeah, I mean, we have printed a few for some people who've asked, but generally they want you to print your own now and look online and just check that you're reading the most up-to-date schedule. So it's just different to what we're used to, and it's just a bit unfortunate, I think, because we all like those big glossy schedules that we had on our walls. And last year they added influenza onto this schedule, and it's obviously there again this year. And then just always please just Bexsero is not given at 6 months of age unless a child is really severely immunocompromised. And we've had a lot of Bexseros given at 6 months of age, and I think that was a fault with the immunisation schedules previously. They just weren't written well. But please don't give Bexsero at 6 months of age unless they have got the real severe immunocompromising conditions. Just which you can check, list them there. And then also there's a bit of a print error with the Rotarix. It's saying that Rotarix can be given by Rotarix needs to be given by 14 weeks, but as you probably all know, it's 14 weeks and 6 days. So we have notified them, but that hasn't been changed yet. And then influenza and Bexsero, they're not linked to family assistant payments. So if you've got, a lot of people have asked, because influenza up there, does that affect that? And will it appear on air if it's due or overdue? And no, it won't. And then I just really want to add that you really have to stick to the schedules. You can't make up your own schedule. We know certain parents come in and they say, oh, I don't want my children to have the Infinrix Hexa. I want them to have 3 Infinrix instead, because I don't want them having all those additional antigens. The schedule's there for a reason. The way how it's funded is that the primary course is funded Infinrix Hexa. You can't start messing around with the vaccines at 18 months, giving them at 2, 4 and 6 months. And the varicella and IPOL are on the adolescent schedule for adolescent catch-up. They're not on the childhood schedule, even though we know that they're registered for that age group. Queensland Immunisation Programme do not supply those vaccines for this particular schedule. So just please try and stick to the schedules, which I know it's difficult when you have some tricky parents come in. This one is the adolescent schedule and the medical at-risk conditions. And obviously the latest change is that we've got Bexsero added onto the adolescent schedule, which I'll talk about in just a moment. And what I did just want to point out is you'll notice this column down the side. It talks about the immunisation handbook. Sometimes it talks about ATAGI statements. So the schedule, it's only really providing you with what's funded and what's due. It doesn't go into sort of like minimum dose interval and co-administration. And really, I know everyone's super busy, but if you're given a medication, you need to know a bit about it, or a vaccine. And there is heaps of supporting documentation to support the programme. So obviously the immunisation handbook is number 1. And then we have ATAGI statements, and then the National Immunisation Programme have documents as well, like the HPV documents that came out when we changed from Gardasil down to 1 dose. And we have things like the decision tree for your pneumococcal to tell you who's eligible and when and how many doses. So you need to sort of be aware of the bigger picture rather than just what the schedule's telling you. Number 1 is the Australian Immunisation Handbook, and call-outs as well. I mean, we take calls all day long, so that's absolutely fine. And then the bottom of that schedule is additional vaccines for medically at risk. And again, this has a huge amount of supporting documentation. So the 2 tables at the bottom is your meningococcal, at the far left over there, sorry. You've got your meningococcal B and your meningococcal ACWI. So if you've got somebody who's medically at risk, you need to hop onto the tables and just see how many doses they require. If you've got a splenectomy patient, there's information in the Australian Immunisation Handbook, but there's also the Alfred Spleen Australia, that's the little table with like the flow charts at the top there. And the very top left-hand corner is the ATAGI statement for medical at-risk conditions, and that's been out since 2020. So there's a lot of supporting documentation with the tables, which we'll take calls and we go through these with you, but it's great if you're able to access that information yourself as well. And it just shows how complicated the immunisation programme is as well, and it causes you guys quite a bit of headache sometimes when you've got like overseas catch-ups coming in and things. So meningococcal B, you'll be familiar with giving that to the Aboriginal and Torres Strait Islander children, but it's now all children, and this is funded by Queensland. So the Aboriginal and Torres Strait Islander programme is funded as a Commonwealth funding, and it's Queensland that have chosen to fund, after a lot of campaigns that have happened, chosen to fund meningococcal B. And you're given in the same doses as you would your Indigenous children. So all infants aged 6 weeks to 12 months get 3 doses, 2 primary and 1 booster. And that's routinely given at 6 weeks, 4 months and 12 months of age. And if, again, it's one of those vaccines where is this vaccine that people have been giving it to at 6 months? I think that was, as I said, a fault from the schedule. Even if a child does get it at 6 months, they do still need that 12-month dose as well, because that 12-month dose is the booster dose that gives them additional protection for longer. And you always have to make sure you've got an 8-week interval. So it's, and then children aged 12 months to less than 2 years, it's just 2 doses if they're over 12 months. And that's if they've not previously had the vaccine. And there's, again, always 8 weeks between the doses. And the Queensland funding is only for 2 years and under. But if the funded meningococcal B vaccine has commenced under 2 years of age, they can complete the course. So if you've got a child that's 23 months and it's your first time catching up with them for a while, you can give them meningococcal B that day and then bring them back 8 weeks later, even though they'll be over 2 years. So they can start the course before 2 years, but they can't after 2 years. Obviously, they can have it private though, so you can always discuss private. It's an expensive vaccine, but if someone's maybe got a child that's getting the vaccine free, but they've got older children that missed the boat, they might want to then perhaps vaccinate the older children, but they would have to pay for them. It's the same advice for the paracetamol as well. So ideally 30 minutes before, then 2 doses, 1 6 hours later, another 1 6 hours after that. So, and if on the day they arrive and you haven't managed to get that initial dose into them, just tell them when they get home to give the child a dose of Panadol. And that's just for the young children, not for the adolescents. And the adolescent programme, it started in February with this year's school immunisation programme. It's already well underway. Those children are getting meningococcal ACWI and they're getting meningococcal B on the same day. And that's given in year 10. And there is catch-up available for the 15 to 19-year-olds. So if you've got adolescents coming in who are eligible, they've not turned 20, they can have the Bexzero vaccine. And if you have got adolescents that are not caught up with their other vaccines, please try and make sure they get them before they turn 20, because once they turn 20, they have to pay for those vaccines. And a lot of the vaccines are very expensive. The only exception is Gardasil 9, that is now funded up until just before you turn 26. And there may be kids, maybe young people in their early 20s, 23, 24, especially boys, because initially the programme only runs for girls. So if you do get people in their young 20s coming through, just check that they had their Gardasil 9, and it is only 1 dose unless they're immunocompromised. Try and use every vaccine or any opportunity you can to look at immunisation histories. And with teenagers, a lot of them might be heading off to uni or the army or healthcare. So if we can catch up with their vaccines while they're free, it's a lot easier for them. And the 2 meningococcal ACWI and Nimerics can be co-administered with meningococcal B. There's a great documentation, a flyer on the Queensland Immunisation Programme website, and one's for provider information and one's for consumer information. It's about 3 pages long and it answers a lot of questions for the new programme that's just started. So it's worth having a look at that. And it's a specific heading of the MNB programme, some good information. So the other new vaccine that came onto the schedule in November for older adults is Shingrix. So it commenced on the 1st of November and it replaced Zostavax, which was the live vaccine. So this Shingrix isn't live, so we don't have all those worries that we used to have with immunocompromised patients. And the eligible groups are Australians 65 years and over who are non-Indigenous. But for Indigenous Australians, they can receive the vaccine at 50. And anyone who's immunocompromised, more sort of solid organ transplant, stem cell transplant, hematological malignancy, advanced and untreated HIV. So it's not just any immunocompromising condition, they're quite sort of specific there. So they're all eligible for Shingrix. And it's given 2 to 6 months apart, 2 doses. And if it fits into the immunocompromised category, it can be given 1 to 2 months apart for that group. So I think everyone's getting quite used to giving Shingrix. I think you had a lot of patients queuing at the door to get this vaccine when it first came out. It is an adjuvanted vaccine, so we are seeing some local injection site reactions such as pain, redness and swelling. So they're common side effects. We're also seeing tiredness, muscle aches, fever and headache. We've actually had quite a lot of adverse event forms come through since November, and it may be just we're given a lot of Shingrix. Now it's got dropped because Zostavac was from 70, whereas this has dropped down to 65 years of age and 50 with Indigenous adults. So I'm sure you're aware that it's probably flying out of your fridge. So I think the fact that we're giving so many means that we're seeing a lot of APHIS, but some people have been really sore arms after the vaccine sometimes, but then there's other people who receive the vaccine and be absolutely fine. So just warn those patients, because if they know in advance, they're probably less likely to be freaked out by it if they're expecting that their arm might be sore. So co-administration, I'll get back onto co-administration again because ATAGI recommends that it is acceptable to administer Shingrix and Fluad Quad on the same day. So obviously they're both adjuvanted vaccines, but it does say in that's on the ATAGI statement, but it also says, however, in the absence of data with Shingrix and specific COVID-19 vaccines or between Shingrix and Fluad Quad that are both adjuvanted, it's preferable to separate by a few days. And this enables any sort of adverse event to settle down before the next potential adverse event. Hopefully there won't be any. But the little sentence at the bottom is taken is another comment from the ATAGI, and it says there are currently limited data on the safety of co-administration of the adjuvanted vaccines Fluad Quad and recombinant zoster vaccine Shingrix. While it is preferred to separate administration by a few days, it is acceptable to co-administer, and this avoids missed opportunities. So you just got to weigh up the pros and cons when somebody comes in. If it's a patient that's one that's very difficult to pin down and you see rarely, or if you work in rurally and you might not see this patient for a long time, then you can make the decision to co-administer, but just have a chat with them beforehand about the potential sore arm. Or if you've got someone and they don't really want to have 2 sore arms or have the muscle ache and everything, they might choose just to separate by, you said you can separate by a few days, but you could bring them back a week later for their next one. So that's you can have that chat with your patients. And there's another one of these national immunisation programme sort of information leaflets here that's on the Department of Australia health website. And this is a really handy one. Again, it goes through potential questions. And one is that comes up quite a lot. I just wanted to point this one out. So this is about patients that have already had Zostavac. So patients who previously received a Zostavac under the NIP can't receive a free Shingrix for 5 years. And they could purchase it privately if they want, but it's based on funding. And they've kind of already received their shingles vaccine. So the NIP don't want to then go and fund another one so soon afterwards. But if a patient purchased their Zostavac privately, they can receive the free Shingrix with an interval of 12 months between the doses. Sorry, won't be a second. All right. What's also new is that now you have to put the vaccine type. So you've probably already started doing that. I think that was from the 1st of March. So with antenatal, even if the patient's receiving a NIP vaccine or a private vaccine or state vaccine, it actually has to be entered as pregnancy antenatal. Most of the vaccines that you give are going to be your NIP and Commonwealth funded vaccines. Private's pretty easy, and new travel vaccines, and then some vaccines fall under the state programme. So just to make things a little bit confusing, Bexsero that's given to Aboriginal and Torres Strait Islander children, that's a NIP funded Commonwealth vaccine, so you will have to click on NIP Commonwealth for that one. However, the Bexsero that's just started this month, that's for all of the children who are non-Indigenous, they actually fall under the state programme, so you'll have to click on state. And then with the influenza vaccine that everybody gives, that falls under the NIP Commonwealth. However, these new flu vaccines that are free, that's your private stock that you're getting reimbursed for, that's the Queensland state that's funding that, so they'll have to click on state. So I'm really sorry that that's so complicated. It's definitely nothing to do with us. We're learning as we go. All right, so I'm just going to, the next slide, I'm talking about the respiratory syncytial virus. So this has just been announced this week. So we've been in quite a few meetings this week. It's all very new for us. So the Queensland government have announced that they will provide Nursvimab, Beyfortus, monoclonal antibody to protect Queensland infants and young children against RSV. And it's commencing, they said on the 1st of May, but it is most likely going to be in 2 weeks' time on the 15th of April. And it's not a vaccine, it's classed as a monoclonal antibody. And it's going to be given to all newborns, so it's going to be in maternity departments, medically at-risk infants and Aboriginal and Torres Strait Islander infants less than 8 months of age. But there are going to be certain medical at-risk infants and young children who will be eligible from 8 months to 19 months. The meetings only took place today. The information only came through to us yesterday, so this is pretty fresh. I've just tried to pull together what I know about it at the moment. Beyfortus is going to be given IM. It's a long-lasting, safe monoclonal antibody. So it provides passive immunity. So you're not going to get lifelong immunity. It's passive immunity for newborns. And it's stored between 2 and 8 degrees. So it's going to be in your fridges. And it's mainly going to be provided at birth in maternity units. And there's going to be consent forms made up that they're working on at the moment. It is going to have to be added to air. It's going to be given at birth, so it's safe to be co-administered with hepatitis B. And then any general practices or AMSs that see a high rate of Aboriginal or Torres Strait Islander children, you are going to be able to have stock in your fridges of the Beyfortus vaccine or monoclonal antibody, as it should be called. And then other services, if you've got a child that you think is eligible, you're just going to have to submit a special order. So it's kind of going to be on a needs basis. They're changing the EPA, the Extended Practice Authority for Immunisation Programme nurses. It's going to be added onto the EPA, and it is actually going to be added onto the immunisation NIP schedule as well. So probably a good job they didn't do a huge printout, because the schedules are going to be changed again. Unfortunately, I can't tell you an awful lot more about it at the moment, because we only received a statement a couple of days ago, and they have said that they're going to provide more information to providers, but I think that they're liaising at the moment through the chief midwife officer and through the maternity and obstetricians. So watch this space. It's evolving as we speak. That's as much as I can say at the moment on that one. COVID-19 vaccine, not many general practices are given the COVID-19 vaccine. A lot more are given in pharmacies than anywhere. There's just been a new ATAGI statement that's just been released. We did print some off, so some of you may have grabbed those. It's still actually managed through the Commonwealth. It isn't managed through Equip. So in tropical public health, we've had very little to do with COVID vaccine, even right from when the pandemic was at its height. So we have no control over the ordering or what's happening with the programme. It's just you order everything through the Commonwealth. And the primary course now is only actually 1 dose, unless you're immunocompromised, which is 2 doses. And then the new statement talks about people that have already had a primary course, what their recommendations are. And the most important people to receive the COVID-19 vaccine are your over 75s. And they're recommended to have the vaccine every 6 months, whether they're immunocompetent or immunocompromised. The 65 to 74 age group, they're recommended every 12 months. But if with any kind of severe immunocompromise, again, they're looking at every 6 months. Yeah, 18 to 64 age group, it's kind of just you can consider whether you want to have the vaccine in consultation with your GP. So maybe if you're going to traveling or if you're living with people who are immunocompromised, and you can that's every 12 months. You can think about having the COVID vaccine. And I listened to a webinar today, and they're not talking about dose 1, dose 2, dose 3 anymore. It's just that year. What have you had your COVID vaccine this year now? We're getting away from the dose numbering. And then your 5 to 17 years, we wouldn't normally be recommending the COVID-19 vaccine unless there's severe immunocompromise there. And under 5s, it's still not recommended. And most people go to their pharmacies for the vaccine now, but I do know there are a couple of practices who are starting to get the COVID vaccine back in. And yeah, unfortunately, you have to liaise everything through the COVAX, or it's not actually through us. So we're not managing that program. We thought that we would be by now. That kind of wraps up the influenza and COVID information. So I'm just going to talk a little bit about vaccine management because it's a huge part of what you do. And I know it's a huge headache sometimes with especially recent weather events. Everybody knows that vaccines are delicate biological substances that are affected by freezing, light and heat. The cold chain is from the moment the vaccine is manufactured all through the journey, right up until the vaccine goes in a patient's arm. You want to keep those vaccines between 2 and 8 degrees. That's a huge part of what you guys do. For us, we manage the breaches. So that's a big part of what we do. And about a year ago, Quip introduced some new thermostability data. So we're just getting used to that now. But each vaccine has its own thermostability data, and that includes like a cumulative time range. So each vaccine gets to a certain temperature for so many hours, and some can, some can't, and it gets very complicated. It's confidential, so we can never share that information. We could never say, oh, the Bexero is fine if it gets up to whatever for however many hours, because the pharmaceutical companies do change that information quite regularly as well with ongoing research. So we get new thermostability data coming through all the time with that information. But it gets really tricky when you have subsequent cold chain breaches. They become very time consuming, because if you've had a breach and your vaccines have been in 4 different SKUs and they all reach different temperatures and they were all in the 3 previous breaches, we have to add up that time and work out what the maximum temperature was for each of those vaccines. So you may notice that we probably take longer to manage your cold chain breaches than what we used to. However, you may notice that we're not discarding anywhere near the amount of vaccines that we used to. So that's why all that working out, all that time of maximum temperature and length of time, it does mean that we are able to keep your vaccines. And that's why we keep asking you to mark them every time you have a cold chain breach, so we know which vaccines have been through which breach. We have an amazing spreadsheet for all of that. And never assume that a vaccine's okay, just because, say, your Boostrix survived the last breach and you had another breach. Please don't think, oh, no, they're okay, because, you know, the fridge got up to whatever and they still said we can use them. As I said, the data does change, and also it's cumulative. So if they've been through a couple of breaches, then sometimes they've run out of time and we do have to discard them. Cold chain breaches are the bane of your life. I know that. I know they give you a very time consuming. Unfortunately, we live in an area where we do have a lot of power outages. But please, the most important thing is the minute you think there's anything wrong with your fridge or you think your vaccines may have been compromised, please isolate them, pop a poster on the door, inform all the doctors and everybody in the clinic. There's nothing worse than having to ring a patient and say, oh, we think the vaccine we gave you, you may have been compromised and we're going to have to give you another one. Please investigate the cause of the breach, because sometimes by the time you've had a look round, you know, you might find that a switchboard has been flicked, or there's an electrician next door that's turned the power off, or cleaner might have unplugged the fridge. So have a good look around before you sort of panic with everything. If you've got time, notify Quip. There is the form there is the form that you fill out. They don't have a phone number anymore, unfortunately. So everything is done online, and that's how we manage it. It started with COVID, and now that's how we manage breaches. So if it looks like your power outage or your fridge malfunction is not going away, please just take your time. Don't grab eskies and throw your vaccines in there and start going to action stations straight away. It's so important that you are fully prepared, that your eskies are chilled, because if you have a vaccine fridge, it's got a nice sealed door on it, it's got a min-max so you can see the temperature, they all have data loggers. At least we know what temperature those vaccines are getting to, which is the most important thing. And it's better to do that than to suddenly haul them all into an esky and the esky is still at 20 degrees, or you've chucked that many ice bricks in there, it's gone to minus, whatever. So please just try and stay calm, because as I said, sometimes by the time you've got everything ready, the power's back on and you know you didn't have to move the vaccines in the end. And please never discard any vaccines until you've received advice from us. And the way how it works, you notify Quip, Quip notifies us, we call you, and then we notify Quip when you're good to order again. Please try and have a sign ready so you can stick it on the fridge door. Try and do some training, some esky packing training. So there's a little video there from the Queensland Immunisation Programme. It's not very long. It's probably about, I don't know, probably no longer than 15 minutes anyway. Try and include it as a bit of a in-service. Your esky packing, there's some great information in the Striper 5. Those photographs are taken from Striper 5. As soon as you know there's a cold chain breach, throw your ice bricks in there, close the lid, just let those eskies chill while you're busy preparing everything else and conditioning your ice bricks that are actually going to be in with the eskies. When it's time to transfer your vaccines, when you're ready, you take those solid ice bricks out and then you layer your esky with bubble wrap, and then you place your vaccines in with a thermometer in the middle. Make sure there's bubble wrap around all the vaccines, and then your conditioned ice bricks, which may take time to condition. Please don't put rock solid frozen ice bricks in there. Place them on top of the esky and around the sides if the esky is a big esky that needs filling. We don't put ice bricks in the bottom because you can't always control what's happening. You can't grab those ice bricks out quickly. And cold air sinks, whereas warm air risers, cold air sinks, so they're better on top and around the sides. And monitor esky for every 15 minutes for the first couple of hours. There's, as I said, there's a video there. If anybody wants us to come and do demonstrations in the clinic and wants to go through cold chain, please let us know. Especially if you've had any big hiccups and you want us to come and do a bit of education, we're happy to do that. Know where your equipment is. So you should have eskies, min-max thermometers, ice bricks, bubble wrap, log temperature books. And then for anyone who's got the soft packs, their soft pack ice sheets just slip down the side. They do not need to be conditioned. You just drop those straight in. So don't leave them out conditioning because they'll warm up. They're ones for the soft packs, just drop straight in. Safety, we've had horrendous weather since Christmas and January, and it's been a horrible time. And some of you have had really awful breaches, and some people have lost their fridges, and some people were out of action for a long time. At the end of the day, they are only vaccines. Please don't venture out into stormy weather or don't take any risks. Just the vaccines are replaceable, so we totally want you to be safe and not risk any your health or your safety trying to save Queensland Immunisation Programme vaccines. When the power comes back on, try and get your vaccines back into the fridge. That's the most important thing, but make sure that the fridge is below 8 degrees. And please just try and document everything during a breach, because it makes it so much easier for us to manage your cold chain breach if we know what time the vaccines were moved, what the temperature of the esky was, and all of that. And then some day-to-day management. Your vaccines should be in baskets in a fridge. They shouldn't be all squashed in like this one here. The vaccines in this one are in a basket in the bottom. Some of the vaccines are out of the boxes. Vaccines should always remain in their boxes. The boxes help with light sensitivity, and they also help with the stability of the temperature as well. Try and have your vaccines on the relevant fridges. You don't want your MMRs mixed up with your MMRVs because there's a risk of giving the wrong vaccine there. And your adult vaccinations, try and keep them separate from your child vaccinations. We do see, with vaccine errors are reported back to us, and these sorts of things do happen. Always try and maintain your vaccine fridge between 2 and 8, twice daily temperatures, first thing in the morning before your clinic starts, end of the day before you go home. Either use the Striper 5 min-max chart or the quick min-max chart. Any sort of deviations, put notes on the back. You know that your vaccine fridge can go up to 12 degrees for no more than 15 minutes for restocking and cleaning. And know how to work your data logger. Everyone who's involved in vaccine management should know how to do a data download. It's not always, it shouldn't be down to just that one person. And ensure that the batteries are changed and that they're serviced as well if they need to be. And with vaccine delivery, just make sure that everyone who receives the vaccines knows where they go and what to do. You don't ever stick a vaccine box in a fridge. You always decant the vaccines, rotate your stock, bring your oldest vaccines to the front and your new vaccines to the back. Vaccine delivery failure, it's actually dealt with by QIP, not us. So there's a form on QIP that you have to fill out and they'll help manage that. There's a new order form coming out, which will be out in the next few weeks. And you are going to be able to order vaccines fortnightly from, I'm not quite sure what date yet, but they have updated them. And you actually are going to order what vaccine, the number of vaccines you want. They're not going to just automatically send you what they think. So they're doing it to try and keep your fridge stock a bit lower, I think, rather than having your fridge full and then a huge breach. And that's the idea. And then don't forget course 4 with the on QIP webpage is all about vaccine management. So any new staff or even reception staff that look after your vaccines, or if you want a bit of an update, or even if you need some CPD, there's a course there. It takes just about over an hour and it's a nice little course on vaccine management. So if you do that with the little video that you can watch, you can nicely cover all your vaccine management CPD needs. And then we're almost finished. So procedures, so important. If you work for CHIS, you'll have a workplace instruction. If you work in general practice, you'll have your vaccine management protocol. Most of you probably know that QIP have made a vaccine management protocol now that they really want everyone to be using. And it's a kind of fill in the blanks, and it has all the relevant links and email addresses, and they want you to review your vaccine management protocol annually as well. So every time anyone has a cold chain breach, we'll always ask for your vaccine management protocol, and we'll make sure that you're up to date. And then finally, maintenance. Please make sure that you have annual maintenance of all of your fridge, your generators, your backup batteries, data loggers. It's so important that your equipment is fully functioning, because that's, if it's not and you're not had your maintenance, that's when you have malfunctions and you're risk losing your vaccines. You should all do a self audit annually, and the self audit is in the it's in the Striper 5. There's a copy of the self audit there. And obviously, if you work for CHIS, Tropical Public Health do an annual audit of all the CHIS fridges once a year. These are all the resources. I've quoted QIP website so many times. If you just get to know the QIP website, everything that you need to know is on there. It's just a case of navigating it. There's other modules you can do as well as the vaccine management one. And then if you need resources such as min-max charts and logbooks, we can provide them. We keep a store of them, but you can also ask for them when you do your vaccine order. You can ask for logbooks and min-max charts as well. And everyone should have a Striper 5 at the side of their fridge with their vaccine management protocol. So that's it. I'll take questions in just a moment, but just to let you know, if you want a certificate, you need to do the QR code. There's an evaluation on the QR code. We probably speak to most of you guys quite frequently anyway, but everyone knows our phone number. Our phone number is there, and that's our email address. Some of you may have our old TPHU one, but it's actually linked into this one, so those emails will come through to us. So please email us if there's anything that you need to know, and if you need any resources from tonight, drop us an email. So it's 5 to 8. We covered a whole heap of things. Does anybody have any questions that